So, Dr. Sriram, welcome to the podcast. We're glad to have you on here, and we're here today to talk about atrial septal defect, aka hole in the heart. So, my first question is what exactly is an atrial septal defect? To a layman, when I hear the phrase hole in the heart, I'm thinking a literal hole in the external wall of the heart. Like someone took a drill, made a hole in the heart, took out the drill, and now there's blood gushing out. And it sounds scary, and it also sounds very contrived. Please tell us what a hole in the heart actually is.
The hole in the heart you're talking about is a non-survivable hole in the heart.
Okay.
And that sometimes happens when you have massive heart attacks, when the wall just caves in, and because lack of blood supply, it gets necrotic, and blood seeps outside, and that usually is the situation where the heart can't work anymore. Heart's normally got 4 chambers, and you have 2 collecting chambers and 2 pumping chambers. The collecting chambers are called atria. Between the collecting chamber there is a wall. The wall is called a septum, and when there's a hole in the septum, it's called an atrial septal defect. Similarly, the ventricular pumping chambers have a wall in between called the ventricular septum, and sometimes you have defects in them called the ventricular septal defect. But today we'll focus on the atrial septal defect.
Okay, so what you're saying is the heart has 4 sections within it, and these sections are separated by a wall. The atrial sections are the top part of the heart, and so the hole is within the gap between the atrial sections.
Correct.
Not on the external walls of the heart.
No.
Okay, cool. So now that we know what it is, I guess my next question is, how common is this condition?
A defect between the 2 atria is present in every growing baby in a mother's womb, because it's essential for survival as a fetus.
So every baby has a hole in the heart.
And that's called a foramen ovalis, an oval foramen. Oval denoting the shape of the defect, and the foramen denoting that it's a hole.
And this is perfectly normal?
This is perfectly normal to have it. And the usual sequence is that as you're born, these defects close because they're more like a trapdoor flap valve arrangement, so that when the pressures between the 2 atrial sides changes, the trapdoor closes and the defect closes.
Okay, so fetus in the womb will always have this defect?
Should almost always have the defect. Sometimes they don't, depending on the anomalies that develop, and sometimes the wall doesn't form, so you have a common chamber between the right and the left atria.
Okay.
So all permutation and combinations are actually possible.
That's scary. It's quite a fragile thing, the heart. But let's say in the normal case, so a fetus is expected to have a hole between the 2 atria, and then post-delivery, once growth occurs, you expect this hole to close up. Let's say it doesn't. What is the frequency of that happening?
Post-delivery, it is not the growth that actually happens. When the fetus is in the mother's womb, there's very little blood that goes to the lungs. So what comes back from the lungs in the left atrium is very little. And this allows the left atrium to be a very lower pressure than the right side, and therefore the trapdoor stays open. So blood from the right side, right atrium, can get into the left side. Now, once you're born and blood flows into the lungs as the lungs expands, and the baby has lost use of the placenta, which was doing the work for breathing for the baby, then you'll end up with more blood coming to the left side. So left atrial pressure goes up, and that closes the trapdoor.
Okay.
Sometimes you may be left with a small continued defect in the trapdoor because of the way it has developed. And very often that is a pointer to how often this is likely to remain open as the baby grows. So if a defect is less than 4 millimeters in size at birth, there's about a 90 to 95% chance it's going to close by 1 year of age.
Okay.
But if the defect is more than 8 millimeters, then only about 20% are likely to close, just ballpark figures. And as you grow, as the baby grows, as the body becomes bigger, more blood flows in the body, and therefore the blood volume goes up, and therefore if there is a defect that is there, it continues to remain open, and the extra blood flowing through it keeps it patent. And so if you look at defects that are more than 8 millimeters, 20% remain open at 1 year, and so the risk of having a persistent defect becomes higher. And the incidence is about maybe 2 in 1,000 births that you can have a hole in the heart that remains open at birth and subsequently.
Okay, so I read 2 to 3 times per 1,000 births online. So 2 to 3 times per 1,000 births, you will have a hole that remains open, or a hole that exists but is likely to close at some point in the future.
Depending on the size of the hole, some will close. Okay. Some may remain small and inconsequential to the health of the patient. Some may remain large and cause physical changes to the dimensions of the heart. And some may remain large, causing so much blood flowing through them into the lungs that can damage the lungs.
Okay, but talking first purely in terms of the frequency of this happening, you would say, so 2 in 1,000 is like a 0.2% rate. So 99.8% of babies do not have a hole in the heart.
That is correct.
Okay, and the rest of them do. The size varies, and depending on that, the possibility of it closing up within a given time period also changes.
Correct.
Okay. Now I want to talk about something that we briefly discussed earlier. This is the concept of pathology versus anatomy.
Physiology versus anatomy.
Physiology. Right, physiology versus anatomy. Okay.
So in principle, when you have changes in structure in the body being a dynamic organism, there are also changes to function. And structure determines function too. And so it's quite important to understand the functional changes that are happening when you put together the combined effects of the structure and the functional changes to the health of the person. And it is a change in the health of the person that determines the need or lack of, or otherwise, of an intervention. And that is how the algorithm follows. So when you have a defect between the left and the right atrium, the first thing to understand is the left atrial pressure is a little higher than the right atrial pressure. So the left atrial will be a mean of maybe 8 millimeters mercury, the right atrium will be a mean of 3 to 5 millimeters mercury. So whatever happens, the blood from the left atrium will flow into the right atrium, as long as the left atrial pressure is higher than the right and there's a defect between the two things. And this flow that happens abnormally between the left atrium and the right atrium circulates into the lungs, but it's already oxygenated blood that's recirculating into the lungs. It comes back to the left atrium and the same cycle is repeated. So the right atrium and the right ventricle receive a lot more blood than they should, because there is this wasted circulation in addition to the normal circulation that's happening. And so the dimensions have to accommodate this extra blood flow, and so they get bigger. And as they get bigger, you have a disproportion in the size of the heart between the right atrium and the left atrium and the right ventricle and the left ventricle. In addition to that, the extra blood that's going into the lungs, how it affects the lung depends on what the lungs can tolerate in terms of the extra blood flow. Sometimes the blood vessels in the lungs are compliant and they may just dilate and allow the blood flow through. Sometimes the extra blood flow in the lungs can actually cause a vasoconstriction or narrowing of the blood vessel. The lung is not able to take this extra flow, and that narrowing can become progressively permanent. Initially it may be reversible, subsequently it can be permanent. If it becomes permanent, then the pressure that you require for blood to get into the lungs becomes much higher, and that is an irreversible change. So that produces a situation where the right ventricle has got to pump again much higher pressure into the lungs, and that's detrimental to your health.
Okay, so you're saying anatomically what's happening is this hole in the heart is causing blood to flow from the left atrium to the right atrium, which is not the flow that we're expecting. And physiologically, what's happening is this enlarges the heart and causes further downstream consequences in the lungs, pretty much.
That's a very nice way of putting it.
Thank you. So now, okay, we know what's happening anatomically, what's happening physiologically. What I'm interested now is what are the odds of this healing itself? You mentioned depending on the size of the hole, there's different percentages, right? At birth.
At birth.
Yeah.
So normally, it depends on where you live as to when you're going to identify this, the defects that are present. If you look historically, most of the time, defects were identified in the 60s and 70s at about maybe the third decade of life, when you would hear a murmur or your heart rhythm will change and you get into a bit of heart failure, breathlessness because your cardiac output has dropped, and then you identify the defect. But this day and age, I think when you have antenatal checkups happening, when you have postnatal checkups happening, the likelihood of you picking it up is much higher than otherwise. And if anybody heard even an inkling of a murmur in the first 3 months of life, off you go to your cardiologist to check it out. And then so you diagnose it very much earlier. And now that puts the added issue about when do you intervene? Should you intervene? When do you intervene? And how should you intervene? And so if you look at principal cardiological practice, it'll be probably one of the most common defects that people see. And if you look at principal cardiac surgical practice, we see patients after they've been diagnosed by the cardiologist and the pediatricians. And so it forms probably about 40% of the work we do.
Wow. And this is heart surgery being done
for
on
children.
Infants.
Heart surgery being done for the pediatric age group, between 0 to 12.
0 to 12 years old. Okay. So now I guess we get to surgery at the point at which an intervention is required. So can you walk me through an example story of a patient who comes to you? Well, obviously the patient in this case is a child. So let's say a mother comes with a baby. What's the initial check that you do? What's the prescribed path you have? And after how long would you determine that a surgical intervention is necessary?
So if you see a patient at say 3 months of age, and you see the patient has got an atrial septal defect, you check on 4 things to make sure that the health is unaffected by the defect, which is color, activity, feeding, and weight gain. If those 4 things are sorted out, then the baby is actually thriving. So there's no overwhelming reason for intervening, unless there are other associated defects which you got to deal with at the same time. But here we're only talking about isolated defects. So normally I would send them off. I'll see them maybe once in 6 months, and we would scan them. We would look at the defect. We look at the size of the heart. We will keep tabs on growth and development, and then usually we would rarely offer surgery in the first year of life, because you would hope that there's always a small possibility, even for an 8 millimeter hole at birth, there's a 20% chance of closing. So this particular patient may fall with a 20% chance. So as long as there are no symptoms, you just wait till they're at least a year in age. And then as the patient grows and develops, and their body size increases, blood volume increases, you'll find the defect also gets bigger. And that's another index where 8 millimeter hole at birth becomes 14 millimeter at 1 year. You know which direction it's going. It's very unlikely to regress. It's more likely to progress.
Yeah.
And then you have to choose a good time for getting it fixed. And the good timing often depends on 1, the type of defect you've got, 2, what it is doing to you, 3, is it possible to wait for the first 2 years of life, because anesthesia has got some implications for cognitive development in young children, and therefore you don't want to subject them to an anesthetic if you can avoid it. So generally you'll wait till they're about 2 years of age. And at 2, there are other issues that come about, which is babies need to go to nurseries, both parents are working, and therefore you want to fix all the defects that are possible so that when they go to school, everything is sorted out, and then they have a uninhibited sort of life after that. So about 2 years is when I actually think most cardiac defects should be sorted out.
Okay. Couple of follow-up questions. So you mentioned the 4 factors that you examine when a new patient comes to you, which are, if I'm not wrong, color, feeding, activity, and weight, right? Why these 4?
Because these are if your color is good, your cardiac output is good, which means not too much blood is being diverted from the left atrium into the right atrium. After all, what comes to the left atrium goes into the left ventricle and goes up in the aorta. If a lot of it goes into the right side, obviously the left-sided structures have got a lot less blood flowing through, and these patients will present as being very pale. And you often think that they are pale because the hemoglobin is low. Very often they are pale because blood is being diverted elsewhere. So color is very important. If your muscles and other parts of your body, including your brain, have adequate blood flow, then you'll end up with activity being very good. Because a thriving child is an active child. And obviously, if there's adequate blood flow to the lungs and the lungs are not too congested, you're not breathless. So feeding will be good. If your feeding is good, your weight gain is good. So these are all markers of health that you follow, and also you can teach parents to follow. After all, they are the ones who are with the patient 24/7. So if they can monitor the color of the baby, they can monitor that the baby is active and is feeding well and growing well. In their own mind, they have confidence the baby is healthy.
I suppose there's no way for the patient to communicate what it's feeling to you, right? Because children only have 2 emotional states, either crying or sleeping. So you do have to look at these signs.
And also mothers are probably very astute in picking up signs of distress in babies. Baby cries can be because of distress, baby cries because it's hungry. And there are distinct differences between one and the other. So very often you have patients coming to your clinic and the baby is crying and you think, does he need a feed? No. The parent says, no, the baby just needs me to walk around with the baby. And I've just fed the baby. So picks up the baby, walks around, and the baby stops crying. So there are many subtle reasons why babies cry. And I think
this is one of the things that
parents will learn and appreciate as it's a progressive learning thing. They will learn and appreciate which is which. And so when parents come and tell you the baby is distressed and is crying, you take it very seriously. Because you're only there for 5 minutes of the time. They are there in the last 24 hours. So what impressions they give you, it becomes serious.
Okay. And I suppose this is where diagnostic scans come in pretty handy as well, right? Because
I think the principal thing is clinical health. So broadly you have 2 categories. You have well patients who have no symptoms, and the 4 parameters broadly are okay. And then you have patients who are breathless or not feeding, and that happens often with ventricular septal defects. And then therefore they cannot feed, they cannot grow, and they are struggling to stay alive. And they are a very different category altogether. And normally for asymptomatic patients, you always do a diagnostic scan, because you not only have to make sure your primary diagnosis is correct, you also got to make sure there are no other associated defects happening at the same time. And also there's no, as you nicely put it, downstream secondary problems that can develop because of the hole.
In terms of diagnosis, what sort of equipment do you use to inspect the size of the hole?
Ultrasonography.
Okay.
The 99% of the issues are settled with a good echocardiogram. An echocardiogram, especially in children, with the chest wall not having so much fat and muscle on it, will give you excellent pictures for you to be able to discern the anatomy very clearly. And that is good enough to make a clinical decision as to what to do. And it's also a non-invasive test. It's got no radiation involved in it. And therefore you can repeat the test as often as you want. And it's a good test for follow-up too. And that's why echocardiography is the only test we use.
Fantastic. I think as an engineer, I'm very curious about how this machine works and what the output is, but not the point of the podcast. What I want to ask you next is, how does it close naturally? Because you mentioned that it does close in many cases over the course of a year.
It is like a flap valve. So if you draw a picture for it, So you have the right atrium coming, you say right atrium is towards me, left atrium is away from me, and the flap valve is this way. And so then what happens, because the septum develops in a very interesting way. So first you have a common chamber, and then a wall falls from the top. As the wall falls from the top, it goes down to the bottom and it separates the two. Then the top part of the wall disappears. And then you land an infolding of the wall redevelops again to create a flap valve.
Wow.
So the blood from here goes through the flap valve to the left side. Then when the left side pressure goes up, flap valve closes.
Forever.
And that's how the hole closes.
Do the flaps kind of fuse together?
They fuse together.
Okay.
And then once they fuse together, there's no more hole. And this is the beauty of the whole system. It remains open, it's functional, it is not necessarily needed anymore. As the physiology changes, baby is born, more blood goes to the lungs, more blood on the left side, pressure increases, flap closes.
Brilliant.
And then the problem solved.
It's a genius system. Okay.
It is such a simple system, isn't it?
So when you say hole in the heart, are you referring to a hole that is caused by the flaps not fully closing, or is it a physical?
Or the flaps have not formed, so that when the pressure goes up there, they don't reach in the middle to close. That the overlap is what allows it to close, right?
Mm.
And when the overlap is not there, and so this top part hasn't developed well enough, and it's not reached where it should reach, you land up with a defect that remains throughout. It is not important when the baby is in the mother's womb, because you still need the hole to happen.
Mm.
So whether it's an anatomical flap or it's or a defect itself, it's irrelevant.
Mm.
Only when you're born and you want it to close, then the material is not suitably opposed for it to close.
Right. So again, then comes back to the idea of what even is a hole in the heart, because when you said a hole between the septum, within the septum,
A defect between the two.
I was picturing, imagine a wall with a literal hole punched through it. But that seems to not be the case. It seems to be a wall that hasn't connected yet.
The wall or the chamber where the construction of the wall began, and the construction of the wall was not just a one wall structure, but it formed in two phases. One phase was the wall forming and the top part disappearing. Second phase was a new wall forming to create the flap valve. Because the aim was to create the flap valve. It's like a cat flap, right?
Yeah.
Aim was to create a flap valve. And the moment your flap valve didn't form, or there was an anatomical limitation to how big either of them was, then you land up with a defect.
Okay, so I'm picturing like a wall that is built from the ground up and a wall that is built from the top down, and they never connected. So there's a whole section missing.
They never connected, except
Okay.
that they should have been offset a little bit
Okay.
for it to function.
Yeah.
So when the pressure dynamic changes on both sides, it can close off.
Okay.
When that doesn't happen, obviously you land up with
A difference.
ability for blood to flow based on pressure gradient. Ultimately, it's all gradient flow, right?
So when you say an 8 millimeter hole, what exactly are you referring to? Is it the height difference, or is it the misalignment difference?
Because the moment you have a defect like that, the misalignment is not the issue anymore. There is an actual physical separation of the two sides, and therefore that is the defect you are seeing. And obviously, it is not a circular thing,
Right.
and therefore
It's not circular.
it's not circular. Because it's not circular, in different views it will be different size, and therefore you will grossly look at the widest side, and that will be the most important measurement you have.
Okay, so we're looking at the widest separation.
The widest separation between the two
between
things,
the two walls.
and that will be what you will think of in your mind as the size of the defect.
Amazing. So it's actually, I think, a problem of nomenclature as well, because it's not really a hole. A hole implies circular, right? It's more like a gap in the heart.
Yes, it can be that, which is why it's called foramen ovale. Some people thought it's oval,
Right.
and if you actually look at it carefully inside,
Yeah.
very often it's not even oval.
There's really no shape.
It's a very variable thing, and it also depends on how big it is. The shape is determined by the amount of blood flowing through it, and sometimes it can be a vertical oval, sometimes it can be a horizontal oval. See,
Wow.
but the one thing it never is round.
Okay. So now the question is, what causes it to close naturally?
When the trapdoors are well formed,
Mm-hmm.
as initially the blood flow to the left side is very little because the blood flow into the lungs is very little. So the blood coming back to the left side is very little. Therefore, left-sided pressure is lower than the right-sided pressure in the fetus.
Mm-hmm.
So blood preferentially flow from the right side to the left side to go to the brain.
Okay.
That's how you get preferential oxygen to the brain.
Mm.
Allows it to grow and direct the operations. Now what happens when you're born? Placenta disappears, lungs open up as you start breathing, so more blood flows into the lungs as the resistance falls. After all, as the lung opens up, the blood vessels open up too. So the resistance to flow drops, therefore more blood flows. As more blood flows into the lungs, more comes back to the left atrium.
Okay.
As more comes to the left atrial pressure goes up. Then it shuts the trapdoor.
Mm.
And it doesn't happen instantaneously, it happens over the first 24-48 hours of birth.
I would assume that for the door to be shut, though, it sounds like the reason the hole existed in the first place is that there wasn't enough wall, right? So to me, it sounds like there has to be some growth of muscle within the heart.
The initial part, the hole remains open, is the pressure difference between the right and left side. And the fact that the two were offset.
Okay.
And the reason it closes is because as the pressure on the left side increases, the wall moves towards the other side. And then the overlap happens.
So it's not a case of insufficient muscle. It's a case of pressure keeping them apart.
Correct.
Okay, got it. And so I guess my next question, which was what would cause the hole to increase in size, would be the exact reverse of what you just described.
What would cause the hole to increase in size? As more blood flows through it and the hole and the body grows, the defect also grows.
In terms of pressure, though, is there an explanation?
After all, pressure, volume, and resistance, right? So as long as your lung resistance is low, there's no impediment for blood to flow into the lungs. And therefore, as long as left atrial pressure is higher than the right atrial pressure, more blood will flow from the left to the right.
Okay. Interesting how much like background physics knowledge you also need to have to explain what's going on over here.
Ultimately, it's all physical changes. You look at the body itself. Body is just set of tubes. If you take away the solid mass, rest is all tubes. In some you have blood flowing, in some you have cerebrospinal fluid flowing, in some you have bile flowing, and some you have urine flowing. And the same thing happens in the gut too. So the physical rules that make things flow in tubes are important here. So you need to understand physical phenomena. You need to understand simple formulae like the Pusey-Hagen formula, which tells you about relationship of resistance to radius. So if your radius goes up, your resistance drops by 16 times because resistance is inversely proportional to the fourth power of radius.
Wow.
So when it comes to tubes, and the only difference is viscosity. So blood has got different viscosity to water, has got different viscosity to urine, has got different viscosity. So the dimensions that you require and the mechanics you require slightly change depending on what fluid needs to percolate.
Amazing. Now we get to the really interesting and intimidating part to me, which is operating on babies. Let's say for whatever reason the gap didn't close up, a year after the patient has visited you, and you decide it's time for a surgical intervention. Can you summarize for me on a high level what are the steps taken within this surgery?
There are two possibilities of closure of a defect. One possibility is you can use a device to close the defect, and this device can be introduced through a vein in the groin, and you can go across the hole and you can put a device. It's called the commonly used device called an Amplatzer device. The upside of an Amplatzer device is you can put it percutaneously, which is you need an anesthetic, of course, but you don't need any cuts to be made in the body other than through a catheter in the groin. The downside of this is that you leave a foreign body inside the heart, which will be with you for the rest of your life. And again, there's also a small risk of this device if it doesn't sit properly, if the walls are not well formed. These devices can escape and can either go to the left or the right ventricle and cause trouble at the time at which it's being put in. Also, if the device is too big, you can erode the heart in due course as the heart starts beating on a fixed structure.
Wow.
But normally, if you ballpark figure, you take all defects, about maybe 40% of patients will be suitable for a device, 40 to 50%.
Okay.
So the others may not have enough structure in the wall to hold the device together, because it's like there are two parts to the device, and it's being held by the wall in between that prevents it from that jams it and prevents it from escaping.
Okay.
So that is one option you have.
And just to clarify, what exactly does the device do?
The device actually blocks the pathway between the two sides. It makes up for the gap in the wall.
Right, so it's literally just a block.
It's just a block.
Okay, it's not actually doing anything intelligent. Right?
It's just doing something intelligent. It's preventing blood from flowing from one side to the other.
Yeah. Okay, what about the other option?
The other option is surgery. And the two ways of doing surgery. The traditional way of surgery used to be you have what is called sternotomy, which is you open the chest up, you put the patient on the heart-lung machine, you stop the heart, you open the atrium, you find the defect, and you close it. And then you get all the air out of the heart, and you get the heart to beat. You close all the holes you have made in the heart. Heart starts taking over. You take off the heart-lung machine, close the wound, go back to ICU, and then you have recovery after that.
When you say it that way, it sounds incredibly simple.
It is fairly well defined. It's a mature procedure. Where people have been doing it since 1960s. So it's got a long history, and it is a very predictable procedure. The flavor of the years now is less invasive surgery, because after all you have to do is to get to the hole and close the hole. That's essentially what you want to do. All the rest is about getting there. And so we have found cleverer ways of reaching the hole, and that's what we call less invasive surgery. So it depends on how big your patient is. If you have an older patient, you can go on the heart-lung machine through a small cut in the groin with the vessels in the groin, and then you have a small cut in the chest through which you can actually access the heart and you can close the hole in the heart. You can stop the heart, close the hole in the heart, all through the small access hole. If you had a child who needs the same thing, you can't use the groin vessels to go on the heart-lung machine, and therefore you need one small cut to go on the heart-lung machine and another small cut to close the hole. But both go through between the ribs in your chest, and so the healing is. And in younger kids, ribs are not fully formed; they're just cartilage, so it's easy to separate them and heal and recover faster.
Okay.
So less invasive surgery is possibly what you want to do for most patients, because you recover faster. You don't have the breastbone which is cut, and it all is entailing troubles of breathing and the way it affects your diaphragm and the fact that it can influence how much activity you can do and the length of time it takes to recover, so on and so forth.
Okay. So it sounds like there's three flavors of the surgery. The first being accessing the heart through the groin to implant a device between the walls. The second is closing the hole in the heart by directly accessing it through the chest. And the third is the minimally invasive route.
Less invasive
which
route.
is through less invasive route. Okay. I'm curious about the second approach. So you said at some point you would have to stop the heart.
Correct.
How does that happen? That sounds very scary.
In principle, what happens once you go on the heart-lung machine, the heart-lung machine takes over the blood flow to the rest of the body, and it also takes care of the oxygenation and removal of carbon dioxide from the blood.
Can you explain that in a bit more detail? So you have the heart and the lungs, and the heart normally.
So in principle, what happens? You have the heart. Heart is basically a pump, and you get blood from the heart coming from two sources. One is from the body after it takes out the oxygen, which is blue blood, and that the heart directs into the lungs. In the lungs, you breathe and you oxygenate, blood becomes pink, comes back to the heart, and is directed to the body. That's essentially what is happening. Now, if you want to take the heart out of the equation, you got to find a way to take the blue blood out, oxygenate it, and pump it back to the body. That's essentially what happens between the heart and the lungs.
And you have to take the heart out of the equation because you can't.
Because you want to work inside the heart.
You can't do it while the heart's pumping.
Some procedures can do on the surface while the heart is working, but to work inside the heart, you can't do it with the heart's beating.
Okay, we're going to get there later about how do you get inside the heart.
Okay, so then you, once you're on the heart-lung machine, through whichever route you want, essentially you bypass the heart and the lungs. That is why it's called cardiopulmonary bypass.
Okay.
You bypass the heart and you bypass the lungs.
Pulmonary being the artery between the heart and the
pulmonary being the lungs.
Oh, it's the lungs itself.
It's the lungs.
Okay.
It's called the pulmonary artery, but the pulmonary is lungs.
Okay.
So you basically got rid of the heart, which is the pump. You've got rid of the lungs, which is the oxygenator.
Okay.
So essentially what do you need? You need a pump outside the body. You need a structure that will oxygenate your blood outside the body. And that's what a cardiopulmonary bypass system does.
Okay, so this gets blood from the heart,
gets blood from the heart, oxygenates it, pumps it back to the body.
Pumps it back to the body.
So that the heart and the lungs can be rested.
I get it. So you're kind of tapping the input before the heart and feeding to the output after the heart.
Absolutely.
And the heart's bypassed now.
Correct.
Okay.
Heart and the lungs are bypassed.
And the lungs.
And so once you've done that, you can block the aorta, which is the main artery coming out of the heart, and then you can infuse a solution which has got a lot of potassium in it. And the potassium leads to the heart going into a diastolic arrest, which means it just stops working. Because the heart is very electrochemical. As potassium goes up, the heart relaxes. And so when you give a ton of potassium, which is what happens in the cardioplegia, your heart just relaxes in diastole. And then gives you an opportunity of opening the atrium and fixing the defect as you think appropriate.
So there's a point in the surgery when you put a solution into the heart and it literally stops beating in front of you.
Correct. It stops beating within about maybe 30 seconds.
How does that feel to you? Like as a layperson, if I were watching this, I would be petrified.
No, if it happens to you without the heart-lung machine, you'll be dead.
Yeah, I imagine.
No, so essentially it's a very controlled thing. And a lot of credit to the people in there's an institute called the Rain Institute in London. I think it's part of the university college, where there's a guy called Dr. Bainbridge who created this process of creating cardioplegia. Since then, this is in the 80s. Since then, 70s and 80s. Since then, it has gone through several modifications, but essentially the principle has not changed.
Amazing. Okay, so now you've got the heart that has stopped beating. How do you access the hole?
Because you already see, once the heart stops beating, you open the right atrium.
So you literally cut the heart open.
Cut the right atrium open. And then once you stay back the edges, you can actually see the defect.
Yeah.
And then 99% of the time you can suture it by direct suture.
Okay.
This is for a standard what we call a secundum atrial septal defect.
Okay.
There are many types of atrial septal defects, but the commonest is the secundum one.
Okay.
And 99% of the time you can actually close it by direct suture.
That's incredible. You can just open a heart, fix it, stitch it back up.
Then stitch it back up.
Nothing happened.
Take the air out of the heart, then you take the clamp off, you perfuse normal blood into the heart. Heart will take over in the next 10-15 minutes.
Yeah.
And then you come off the heart-lung machine, you stop the bleeding from all the suture lines, you close the wound, you go back to ICU and you recover.
That's insane. So it sounds like quite a robust organ.
Its robustness is more related to its simplicity of function. As long as it's got good blood flow happening to it, it'll work for you.
Amazing. A stupid question for you. How does an atrium feel?
Soft, I suppose. Most of the time, the atria we are feeling are atriums that have diastolic arrest. So it just feels like soft muslin cloth. Maybe a bit more firmer than a muslin cloth, but it's very soft.
So you can press it, you can bend it.
Yes, you can compress it. You can feel it.
To me, it's just so crazy because the heart is one of those things that
It depends on
it's quite scary, you know.
It depends on which part of the heart you're talking about. The atrium is very soft. The ventricle is more muscular. So it'll feel like any muscle anywhere else. It feels bulky.
It just sounds wrong to me that a heart can be touched and felt.
No, you're going
It's like a brain, you know, you should not be touching that.
You're going back 100 years now. Because one of the first operations on the heart done was by a guy called Henry Suter, Dr. Henry Suter in London. And he opened up the mitral valve in a patient with rheumatic mitral stenosis. And nobody referred another case to him because they said, you've tampered with the seat of the soul.
Wow. Yeah.
But that is the most pioneering things to have been ever done.
Yeah.
Where they completely changed what humanity could achieve.
Interesting. Okay, now we get to the post-surgical care. So once the baby is in ICU, and
so once you come off the
following
heart
that in
lung
the ward,
machine, you stop the bleeding, you close the wound, and you come back to intensive care. When you come back to intensive care, usually you land up with a set of lines that you have inserted into the patient to give medicine, to monitor blood pressure, to monitor urine output, and then you'll have drains inside which go inside the chest to prevent fluid collection inside. And usually the next 24 hours the baby is woken up, you assess the brain, assess the lungs, assess the heart, assess the liver, assess the kidneys. If everything is okay, you come off the heart lung machine, and then you will probably lose your drains in 24 hours, and then you establish feeds, you go back to the ward, you transition care to the parent, and once they are happy looking after the child, you send them home.
Any possible complications during this process?
Every surgery has got so many components to it, and each component has got a fallibility attached to it. So an anesthetic, for instance, means that you have so many drugs pumped into you, and you must not be allergic to them, or you must not react adversely to them. Adversely can also mean that the volume given with standard calculations you have of how much to give may be too much or too little for you. Then you have blood and blood transfusion that can happen, and so you need to have compatible blood, and those can produce reactions in your body. Then you have the actual surgery itself, which is physical trauma to your body, and you have to react to it. You're on a heart-lung machine, so then you'll end up with an inflammatory response that happens in your body as a reaction to being on the heart-lung machine. As your blood goes through foreign surfaces, there's always inflammation that's happening. So you have to deal with that, and that's usually a 72-hour process. And then you'll end up with post-surgery bleeding, heart rhythm, brain being okay when you've been on the heart-lung machine. Because when you're on a heart-lung machine, you'll always land up with having so-called non-pulsatile flow. Normally, you can feel your pulse in your artery. There are big pulsations, and when you're on a heart-lung machine, you have steady-state flow, not pulsatile flow, and so that can affect function of your organs too. And these are the sum total of these are the so-called risks that you are subjecting yourself to. Only plus is the body is quite robust. So the moment you do a definitive procedure and your patient is not bleeding to death, usually all these changes that you have will correct themselves in the first 72 hours.
Okay.
And then you, as good as new, and then you have the advantage of your heart being more efficient. So blue blood goes to the lungs, red blood goes to the body, and there's no mixing anywhere. It's a good thing.
Okay.
It's a good thing for growth and development, right? So as you grow bigger, you want the simplicity of flow to be restored in the body. Yeah.
Is there any rehabilitative period for the patient post-surgery?
Yeah, usually for the first 2 weeks, if you look at children, the first two weeks you tell them you can only sponge the baby because you want the wounds not to get too soggy. You don't want them to put in a bath with bath water. And after that, rehabilitation is a function of age of the patient, right? So the older the child is, normally they are running around after 2 weeks after surgery. And for the younger ones, usually they're feeding and doing normal things by about 2 to 3 weeks. So usually that determines how you follow them up. So you see them immediately a week after they go home, then you see them in 2 weeks, by which time most medication are off. And then you see them at about a month and about 3 months to make sure you're not You don't have any complications, you don't have any wound issues, you don't have any fluid collecting around the heart, they call effusions. And then by 3 months they are well enough, you send them back to the pediatrician.
Fantastic. What about long-term implications of this kind of a surgery?
Normally once it is done, the only long-term implication you have is a function of whether your surgery is complete and they've not left any residual hole behind. That's the first thing. Or you've not missed a hole elsewhere. This happened before. Or you'll end up with having surgery in patients in whom there are downstream troubles in the lungs, and so those need to be managed too. And so a lot of the issues that in the follow-up are a function of secondary changes and in the function of the conduct of the procedure. The procedure is correct and there's no secondary changes, you're near normal life. And then I usually discharge my patients after about 3 to 6 months.
Okay, so it sounds like a fairly routine and safe procedure.
It's a mature procedure where we've done it before and others have done it before, and you get standard good outcomes. You can keep your risk of dying from this procedure to under 1%. And it's very unusual for a patient with an atrial septal defect to perish. But sometimes you have other things that can happen in the heart synchronously. Abnormal ways in which the conduction system works, and so on and so forth. And you need to factor those things too. And so it's quite important the first 24-48 hours to watch them very carefully to make sure that there's nothing else going on. And so these checks that you're doing pre-operatively, you do it intraoperatively, you do it post-operatively to make sure that you can reach this near 0% risk of dying.
Okay.
I think the devil lies in the detail. And I think most important thing to learn in cardiac work is diligence. And diligence to follow a process every single time to the same detail.
So it's like you bake in safety in every step of the process.
Absolutely.
You have to, right? Because it's a life at risk.
And every step you do, you cross-check before you do the next step. And that is the built-in safety mechanism you have in every step of cardiac surgery.
I guess that comes nicely to how you feel about these surgeries. Do you ever have a moment, post a successful surgery, a discharge of a patient, where you just sit and you are wowed by what has just happened?
No.
That you've operated on a literal baby?
No, but you often are wowed by the fact that nature gives you an opportunity of doing things to it, and it still survives your insult. But the more important thing, I think, is you often audit yourself to see how you could have done it better next time. And that is the learning in every case that you do.
Does it feel different doing surgery on an adult versus a baby?
Every human being has got a right to good health. And all you're trying to do is to provide the good health. Except that in an adult, you have communication of directly between the person and you. And in a child, I think you have an indirect communication through the parent. So you feel a lot more fallible and not fallible is not the right word. You feel a lot more insecure when you're treating children because you don't quite know if all the issues that the baby is having and feeling have been addressed to. Well, an adult, you can be certain of that.
Yeah.
And that's the difference.
But
so you got to be a lot more careful about how you deal with them, and therefore you examine them more carefully. You watch them more intently. You follow them up more regularly than an adult. Because an adult not well, he phones you up and says, "Doc, I'm not okay."
Yeah.
Then you see him straight away.
Yeah.
Well, in a kid, by the time the mother figures it out, it'll be a lag.
That this is a new type of crying.
Correct. And by the time she figures it out that she needs help with you, there's another lag.
Yeah.
So I think those gaps need to be filled in when you're looking after children.
But once you're there in the operating theatre, whether it's an adult or an infant, it's flesh and bones.
It is. It's a process you have to follow, and you have to get into a zone in your mind as to what you're there for. You've got to make sure your team understands the procedure. So I'll give you a simple example, right? So patient is prepared for surgery, blood tests have all been done, all the tests have been done before surgery. They come in the morning, they are checked, everybody checks. There's a whole lot of checks you do in a hospital to make sure you have the right patient going for the right operation. And you've got to make sure your consent is properly done. Then they go to the operating room. There's a check, the anesthetist then anesthetizes the patient, then he inserts lines into the patient, then you position the patient, and then usually the parent comes till the point at which the anesthesia happens, and then the parent leaves. And then you'll end up with positioning the patient, and you do the surgery. And so before you do the surgery, you have a checklist. And the checklist includes what we call timeout, where everybody is there to you decide the right operation is being done. So you have a time in when the baby comes into theatre, where you check to make sure with the parent there that this is what is going to be done, this is the process, and then once that finishes, before you start, again the same thing is reiterated to everybody. In complicated procedures, very often you would sit down and you discuss the details with your entire team, which is yourself, your anesthesiologist, your assistant, your nurses, and the perfusionist, the people who run the heart-lung machine. So that everybody's on the same page. And then the procedure happens. When the procedure finishes, you recheck again. This time with echocardiography too, to make sure that the defect is actually being accurately repaired. And then before you exit theatre. So before you exit theatre, all this happens, and all this enhances safety of what you're trying to do.
As you say that, and I'm sure we can do a whole separate episode on this, but it just strikes me how surgery is really a team sport.
It's 110% team sport. Everybody needs to know their work. Everybody is given clear tasks to do, and everybody's just got to fill in. And I think it is, but you're the leader of the team because you are responsible for the entire process, and therefore it's important for you to recognize what everybody is doing. So you also give them opportunities during surgery to see what is happening. Like I always have a camera in the operating lights. And so my perfusionist who is sitting down and running the heart-lung machine at every point in time can see the images to see at what stage I am. If I'm having difficulty, they can see what stage I am. If the heart is filling up with blood and I'm not able to see, they know they need to drain it better. So you provide everybody with checks and balances and technology to aid and abet in their understanding of what is going on. So everything's only then it flows seamlessly.
Brilliant. Lastly, I wanted to ask you if you have any personal anecdotes with a patient that you have performed an ASD surgery on, which you may have seen later on in life.
Oh, children don't remember you. I think the only time they remember you is in the first 6 weeks, and they're petrified of you. And the moment they see you, they start crying because they think you inflict pain. And you inflict not only pain, you inflict a threat to their happiness and the bonhomie they're having with their parents.
Yeah.
You're the external factor. And of course, parents are very happy that you treated them. But the kids are crying when they come and see you. And but in the long term, I think you do see patients whom you've operated on 25 years ago, and when they get married, they want to come and have a checkup with you to make sure that they can have a family, so on and so forth. That's the happy part of it.
Yeah, you've touched the seat of their souls.
I would go so far.
Okay, Dr. Shankar, thank you very much.
Big a pleasure.